we had the HER2CLIMB trial at Emory, which was a tucatinib-based trial for HER2-positive metastatic breast cancer, again in a heavily pretreated population. And I think one of the exciting results that came out of that was the CNS response, about 42% CNS response with tucatinib. And I think one of the what we're looking for now in some of our novel therapies is for enhanced responses and improvement in CNS disease, because unfortunately that does seem to be a place where we're lacking in terms of treatment for HER2-positive metastatic breast cancer patients. We do have other trials also looking at combinations of CDK4/6 inhibitors along with endocrine therapy and anti-HER2 directed therapy for the triple-positive metastatic population. And we had a trial called the Patino trial at Emory, which was open, and soon we'll get more of those trials at Emory as well. So I think we have some very exciting combinations that we'll bring to Emory, and exciting combinations for our metastatic breast cancer patients.
One of the goals right now that we're hoping to do is to incorporate immunotherapy into this HER2-positive setting. One of the ways that we are doing that is partnering with Moffitt and the University of Washington to offer a vaccine approach for patients who have residual disease that were treated for HER2-positive breast cancer. So looking at these patients to see if giving them a vaccine that is either based on their residual tumor or peptide, to see if that is going to help increase surveillance and help lower their risk of recurrence later.
One clinical trial that we will soon be opening is examining olaparib in combination with palbociclib and fulvestrant for patients with BRCA-associated hormone receptor positive metastatic breast cancer. And the question is this combination going to be tolerable, noting that there are some overlapping toxicities? And the second question is this combination going to be effective, noting that olaparib targets these, is effective in these cancers because it targets DNA repair, and palbociclib and fulvestrant are effective in these cancers as well. And will the combination kind of simultaneously target two drivers of tumor growth and result in better outcomes for our patients? So I'm excited about that trial. It's about to open.
The first is building on combination therapies. So we've been involved with development of sacituzumab govitecan, the antibody drug conjugate for metastatic triple-negative breast cancer. We see a response rate of more than 30%, but I want a response rate of 50, 70, 80%. I want to push that bar. And I think in part it would be understanding the patients who respond very well to single agent, and then also understanding patients who had some response but improving that response. And for the latter category, we would need combination therapies. So we're working both in the lab as well as the clinic to develop combination therapies, and I'm particularly excited about the combination of sacituzumab govitecan with a PARP inhibitor, because I think that could potentially push the boundary in terms of improving survival. The second thing that we are excited about at our institution is understanding racial disparities. We've established a collaboration with Boston Medical Center to understand the issue of racial disparities related to triple-negative breast cancer, and then also from a biology perspective, understanding why African Americans have triple-negative breast cancer as opposed to hormone receptor positive breast cancer that is more common in the Caucasian population. And the third thing is circulating tumor cells. Patients who have triple-negative breast cancer have a different biology as compared to hormone receptor positive breast cancer. If we can isolate the tumor cells and generate models, we can develop specific combination therapies that are targeted to that particular phenotype. So in the lab, we've been interested in developing what we call ex vivo models from patients' circulating tumor cells and doing drug sensitivity experiments. And if we can really figure out a very potent combination, potentially that could be applied back to the patient. So it's very early days, but the promise is on the lines of infectious diseases, where you have an infection, you can do the blood culture, identify that this bug is sensitive to this antibiotic, and then give that antibiotic to the patient. So it's a similar concept. We culture circulating tumor cells, identify for this individual what would be sensitive in terms of drug combinations, and then apply that back to the patient. It's not ready for prime time, but it's something that could potentially be very promising.
Well, we're actually focusing on graft versus host disease as one of the complications of stem cell transplant and trying to find ways to minimize this toxicity to make transplant more effective in curing patients. So there are several strategies and different research things that we're looking at. One is a naive T-cell depletion of the stem cell graft that our stem cell transplant director, Dr. Schlamczyk, has been pioneering. But I'm also looking at some novel strategies using drugs for chronic graft versus host disease. A lot of the drugs that we actually use currently in oncology for other diseases like B-cell cancers, for example, actually can also help treat chronic graft versus host disease because of the pathophysiology involving B cells. So we're trying to look at some of these strategies as well.
We do have upcoming 2 CAR-T studies that will be open for patients with multiple myeloma who have failed 3 lines of therapy and refractory. And we will have 1 single-arm study, and we will have a randomized trial that will compare CAR-T to standard therapy.
We are actually opening the CAR-T cell trial here very soon, along with the trials with daratumumab, with Revlimid and dexamethasone in newly diagnosed non-transplant eligible patients. So these are the trials that we are currently opening in our institution.
For the University of Pittsburgh, we did participate in a number of clinical trials. For the non-Hodgkin lymphoma, we participated in a trial with polatuzumab in combination with CHP and Rituxan for the frontline large cell lymphoma. The trial just closed last week, and we'll see the report. And by the way, we're opening new trials using polatuzumab in combination with other active agent such as anti-CD47 antibodies, which show very active in some of the lymphomas. So this trial is ongoing. We're really excited about this clinical trial. It's open right now for the diffuse large B-cell lymphoma. And the other trial also ongoing right now. We are CAR-T cell therapy for relapse or refractory diffuse large B-cell lymphoma compared with the bone marrow transplant. Currently for relapse diffuse large B-cell lymphoma, transplant is standard of care, but this standard of care being challenged compared with CAR-T. So we have 2 trials in the intergroup studies, phase 3 trials use CAR-T for large B-cell lymphoma. In addition to these 2 trials, we also have a trial combined with venetoclax plus CD9K CD plus MCL1 inhibitor in a relapse refractory non-Hodgkin lymphoma. This is another very active area being investigated, and this trial is in the process of being opening in a month or 2. So this is a trial for the large cell lymphoma. For follicular lymphoma and indolent lymphoma, such as marginal cell lymphoma, we do have a CAR-T program or CAR-T clinical trials. For the follicular lymphoma, their trial just complete, but for marginal zone cell lymphoma, the trial is still ongoing. I don't meet the accrual yet. So for people who are interested in this CAR-T, clearly we have more. In the meantime, we have more trials coming along. Please check our website for immunotherapy or CAR-T clinical trials.
There's lots of interesting stuff going on in the world of AML. Primarily, the new buzzword across oncology is immunotherapy. And there's a number of new agents, both approved and not yet approved, that use antibody-directed therapies. There are studies going on nationally. We're doing some of them here at UPMC using BiTE technology. And there's a lot of early enthusiasm that CAR-T therapy might have a role in treating AML. The challenge now is to find the best target in AML, but there are early trials that are ongoing.
We will be opening the first lorlatinib combination study in the next 3 months. And I think this is a very important study for our patients with ALK-positive lung cancer, because at some point it seems like all of our patients will develop what we call ALK-independent pathways or bypass pathways of resistance. And so these combinations are coming at a very important time for many of our patients who are relapsing. And this combination study really is designed to target pathways that we and others have shown mediate resistance to lorlatinib and other next generation inhibitors. So we're not picking random combinations, but these really are combinations that we believe are going to be highly effective for many of our patients.
We've been conducting a study combining olaparib with temozolomide in small cell lung cancer, and we've seen really encouraging results from the first cohort of patients treated, with a response rate of about 41% among 48 evaluable patients in the first cohort. We're now expanding that study to investigate a slightly different dosing schedule for patients that we think may have potentially increased activity. So we're eager to enroll patients to that study and hopeful that this could potentially be a new option for patients going forward.
We're doing a lot of work focused on biomarkers, using biomarkers to predict responsiveness to checkpoint inhibitors. So one of the key efforts that we're leading at Mass General, as well as collaborators at Memorial, Johns Hopkins, MD Anderson, really a number of different centers, is through Stand Up to Cancer, where we're looking at predictive biomarkers of response to checkpoint inhibitors. Now, most of these are in the stage 4 setting, but we're trying to leverage comprehensive genomic profiling, so whole exome sequencing, RNA sequencing, and multiplexed immunofluorescence of the tumor immune microenvironment to really provide a holistic view and develop better biomarkers of response to checkpoint inhibitors, because we recognize that the current biomarkers, most notably PD-L1 expression, are really insufficient. And these are the types of translational studies that really can't be done in isolation by a single institution. It really requires collaboration throughout the country and throughout the world.